Hello everyone, it's Mimi here. BMS working in the NHS. And today's video will be about gastrointestinal and hepatobiliary histology, which is part of the IBMS specialist portfolio in cellular pathology. So, just a quick introduction to this video. It will be short and sweet, I promise. I will discuss rationale and aims, learning outcomes, indicative content, resources, submission of evidence, Q&A ideas, evidence ideas, reflective statement, and some helpful tips to make candidates' portfolio better. With all that said, I hope you will enjoy the content of my video and I hope you will learn a lot. So let's dive into this submodule. Rationale and aims of this submodule outline the general information and expected knowledge and competence that candidate needs to be achieved when this submodule is completed. These are relevant to each submodule. For this submodule, the expectations are that the candidate will be able to prepare, process, and stain gastrointestinal and hepatobiliary histology tissue samples. Understand the pathological basis of disorders of the gastrointestinal tract and hepatobiliary system. Understand how these disorders may be investigated histologically. Understand tissue selection protocols and block selection. Understand the variety and applications used in the investigation of gastrointestinal and hepatobiliary histology. Identify normal and abnormal tissue. Gastrointestinal and hepatobiliary includes anus, small intestine, large intestine, rectum, appendix, gallbladder, liver, and esophagus. The learning outcomes demonstrate candidates' knowledge, skills, and competence in this submodule. They also include demonstration of the understanding of scientific principles, laboratory procedures, quality assurance, and professional conduct. They allow candidate to work autonomously and solve problems independently. First learning outcome is, discuss how the anatomy and pathophysiology of gastrointestinal and hepatobiliary systems interact. Candidate needs to know how anatomy and pathophysiology of gastrointestinal and hepatobiliary tissue interact. Does the candidate know what is the anatomy and physiology of gastrointestinal and biliary tissue? Do they know how anatomy and pathophysiology of gastrointestinal and hepatobiliary tissue interact? Normal anatomy and function and overall structures like mucosa, submucosa, muscularis externa, serosa, or adventitia. Esophagus and its four main layers, mucosa, muscularis externa, and adventitia. Muscularis externa transition from skeletal muscle to smooth to facilitate peristalsis, epithelial transition from stratified squamous to columnar in GOJ, upper and lower sphincters, anatomical constrictions, cervical, thoracic, and diaphragmatic. Large intestine and its four main layers, mucosa, submucosa, muscularis externa and serosa, regions like cecum, ascending, transverse, descending, sigmoid colon, rectum and anal canal, teeny E. coli bands of smooth muscle, haustra the segmented pouches, omental appendices, the fat-filled pouches. Small intestine and its four main layers, mucosa, submucosa, muscularis externa, and serosa, regions like duodenum or the mixing bowl, jejunum where the absorption happens, and ileum, plicae-circulars the circular folds. Stomach and its four layers, mucosa, submucosa, muscularis externa and serosa, anatomical regions, cardia, fundus, body, antrum and pylorus, muscularis externa three muscle layers to facilitate churning, its characteristic J-shape. Liver and four hepatic lobes, right, left, caudate and quadrate, 8 functional segments with their own circulation, ligaments like fossa coronary, dual blood supply, hepatic portal vein and hepatic artery, lymphatic drainage that can produce between 25 to 50% of total lymph. Appendix, abundant goblet cells, lymphoid tissue in lamina propria and submucosa, simple columnar epithelium. Gallbladder, lack of muscularis mucosa and submucosa, mucosa and prominent folds, simple columnar epithelium, Rokitansky-Askoff sinuses. Abnormal anatomy and overall pathophysiology and changes to the structures and the effect this has on the function of the organ. For example, epithelial or mucosal changes and inflammatory conditions, muscle dysfunctions and motility disorders, enzymatic deficiencies and malabsorption, problems with bile production or concentration, cell damage leading to necrosis or fibrosis, abnormal cell growth, esophagus and neuromuscular degeneration leading to motility disorders like achalasia or spasms, mucosal breakdown leading to inflammatory disorders like GERD reflux or esophagitis, structural and mechanical disturbance leading to hiatus hernia, diverticula, or stricture, abnormal cell growth leading to cancer like esophageal SCC. Large intestine and mucosal inflammation leading to inflammatory disorders like ulcerative colitis or Crohn's disease, neuromuscular degeneration leading to motility dysfunction like IBS or Hirschsprung disease, structural and mechanical alterations leading to diverticular disease, obstructions, and volvulus, vascular alterations leading to colitis, abnormal cell growth leading to cancer like colorectal adenocarcinoma, small intestine and epithelial damage leading to malabsorptive disorders like celiac disease or tropical sprue, immune-mediated inflammation and Crohn's disease, altered fluid and electrolyte transport and diarrhea, bacterial overgrowth, mechanical and vascular alteration leading to acute mesenteric ischemia or obstruction, abnormal cell growth leading to cancer like neuroendocrine tumors. Stomach and mucosal damage leading to infections or ulceration, inflammation, neuromuscular alteration leading to motility dysfunction like gastroparesis, secretory alteration leading to Zollinger-Ellison syndrome, abnormal cell growth leading to cancer like gastric adenocarcinoma. Liver and cellular damage leading to necrosis or fibrosis, structural changes leading to cirrhosis, portal hypertension leading to splenomegaly or ascites, metabolic changes leading to steatosis, abnormal cell growth and cancer like HCC. The second learning outcome is, discuss how pathological processes including inflammation, neoplasia, and infection relate to gastrointestinal and hepatobiliary tissue. Candidate needs to know how inflammation, infection, and neoplasia affect gastrointestinal and hepatobiliary tissue. Does the candidate know how inflammation, neoplasia, and infection affect gastrointestinal and hepatobiliary tissue? Do they know the difference between inflammation, infection, and neoplasia in gastrointestinal and hepatobiliary tissue? Do they know what are the pathological processes of inflammation, infection, and neoplasia in gastrointestinal and hepatobiliary tissue? Do they know what are the histological features of inflammation, infection, and neoplasia in gastrointestinal and hepatobiliary tissue? Candidate could consider inflammation and its acute and chronic type, cellular infiltration, tissue damage, vascular changes, loss of various functions, histological features specific to each organ. Neoplasia and benign and malignant cancers, nuclear features, cellular appearance, architectural changes in tissue, altered differentiation, uncontrolled abnormal growth, tumor formation, bleeding, polyp formation, changes in systemic and metabolic functions. Infection and pathogen invasion, cell injury, inflammatory response, ulceration and tissue destruction, perforation, cirrhosis, pathological processes and act on histological features. The third learning outcome is, explain when and why samples of gastrointestinal and hepatobiliary tissue need to be prepared prior to dissection, as well as how this should be done. Candidate needs to explain when and why are gastrointestinal and hepatobiliary samples prepared prior to dissection. Does the candidate know how are gastrointestinal and hepatobiliary samples prepared prior to dissection? Do they know the steps taken during gastrointestinal and hepatobiliary sample preparation? Candidate could consider orientation, description, weighing, measuring, inking, opening longitudinally, slicing, sample types like biopsies, polyps, partial organs, and the difference how they prepare them. The steps might be specific to each department, but they should consider SOPs, methodology used or RCPath and NICE guidelines. The fourth learning outcome is, explain dissection, tissue selection protocols and block selection rationale for samples of gastrointestinal and hepatobiliary tissue, as relevant to your lab. Candidate needs to explain dissection and tissue selection for gastrointestinal and hepatobiliary tissues. Does the candidate know gastrointestinal and hepatobiliary samples dissected in your lab? Do they know what blocks are taken and why? Candidate could consider gross examination, description, slicing and opening, systematic sampling approach to obtain adequate representation of pathology, block selection, sampling lesions or abnormalities, multiple blocks for larger tumors, lymph node assessment, assessment of resection margins, inclusion of normal tissue, specific anatomical landmarks like cystic duct or hilar margins. The exact steps are specific to each department and each gastrointestinal and hepatobiliary organ. Therefore they should consider SOP, methodology used, RCPath and NICE guidelines. The fifth learning outcome is, describe how normal and abnormal gastrointestinal and hepatobiliary tissue stained using H&E should appear when viewed with a microscope. Use examples relevant to your practice. Candidate needs to describe normal and abnormal gastrointestinal and hepatobiliary tissue on H&E stained slide. Candidate know how normal and abnormal gastrointestinal and hepatobiliary tissue stained with H&E look like microscopically? Can they identify abnormalities microscopically? Can they identify gastrointestinal and hepatobiliary tissue on stained slides? Do they know the characteristic features of gastrointestinal and hepatobiliary tissue that can be used to identify it? Overall, candidate could consider layers like mucosa, submucosa, muscularis externa, serosa, adventitia, cellular changes, architectural changes, cell organization, and special features for each GI organ. Esophagus non-keratinized stratified squamous epithelium with reedy ridges, GOJ junction, submucosal glands, muscularis externa transition from skeletal muscle to smooth to facilitate peristalsis. Large intestine and simple columnar epithelium, lack of microvilli, crypts of Lieberkühn, cell types like cells for mucus, protection and lubrication, colonocytes for water and electrolyte absorption via inconspicuous brush border, enteroendocrine cells for hormone release to regulate gut motility, small intestine and simple columnar epithelium with microvilli, villi and crypts of Lieberkühn, Brunner's glands, Peyer's patches, types like Paneth cells that secrete antimicrobial peptides, enterocytes for absorption of nutrients via their brush border, scattered goblet cells for mucus production to lubricate food passage and protection, scattered enteroendocrine cells as chemosensors to regulate digestion. Stomach and simple columnar epithelium, gastric pits, specialized glands, 3-layer of muscularis externa to facilitate churning, cell types like basophilic chief cells for pepsinogen, eosinophilic parietal cells for hydrochloric acid, mucous neck cells for protective mucus, enteroendocrine cells for gastrin secretion. Liver hepatic lobules, canaliculi, fenestrated sinusoids, space of D's, portal triads consisting of hepatic artery, portal vein and bile duct, central veins, cell types like hepatocytes, Kupffer and stellate cells, appendix and simple columnar epithelium, lymphoid tissue in lamina propria and submucosa, cells like abundant goblet cells for mucus or microfold cells around lymphoid follicles. Gallbladder and simple columnar epithelium, lack of muscularis mucosa and submucosa, prominent folds in mucosa, Rokitansky-Askoff sinuses, cell types like cholangiocytes for bile concentration, goblet cells for mucus or tufts as chemosensors. This is very specific to each organ and pathology. Therefore, candidates should consider abnormalities and how they affect the histological features seen microscopically. The sixth learning outcome is, explain when and why special stains, IHC markers, and other specialist histology techniques might be required to demonstrate abnormalities of gastrointestinal and hepatobiliary tissue. Identify all the relevant stains and techniques. Candidate needs to explain the use of IHC and special stain gastrointestinal and hepatobiliary tissue. Does the candidate know why and when would special stains and IHC markers be used to stain gastrointestinal and hepatobiliary tissue? Can they give examples of staining techniques used for gastrointestinal and hepatobiliary tissue? Do they know why they would be used, and explain what they act? Candidate could markers like cytokeratins, prognostic, for guiding therapy, for subtyping, for detection of mucins, glycogen, reticular fibers, iron, lipids, or infections. Specific IHC markers like AE1/3, CK8/18, CK20 for epithelial lineage, Ki67 for proliferation, MMR panel for Lynch syndrome, HER2 to guide therapy, HEPR1, CA125, DOG1, SOL4 for subtyping. Specific special stains like AB, AB-PA, AB-PAST for mucins, PA and PAST for glycogen, retic for reticular fibers, pearls for iron, oil red O for lipids, gram, gimsa, orcean for pathogens. The seventh learning outcome is, describe the staining patterns you would expect to be able to view microscopically for each of the IHC, special, and other staining techniques listed above. Use examples relevant to your practice. Candidate needs to describe staining patterns in gastrointestinal and hepatobiliary tissue. Does the candidate know the staining pattern of IHC and special stains for gastrointestinal and hepatobiliary tissue used in your lab? Can they recognize those staining patterns on stained slides? Can they distinguish between abnormal and normal staining pattern? Candidate could consider normal and disease-related staining pattern, marker, and stain-relevant pattern localization patterns like nuclear, cytoplasmic, membranous, Golgi or mixed staining, intensity of staining like negative, weak, moderate, or strong. Distribution patterns like diffuse, focal, heterogeneous, or peripheral. The eighth learning outcome is, demonstrate how you are involved in any part of the process between tissue preparation and reporting for a gastrointestinal and hepatobiliary tissue sample. Candidate needs to demonstrate their involvement in gastrointestinal and hepatobiliary tissue processing in the lab. Is the candidate involved in gastrointestinal hepatobiliary tissue processing in the lab? Can they explain their role in the process between gastrointestinal and hepatobiliary tissue preparation and reporting? What tasks do they perform in the lab that are relevant to gastrointestinal and hepatobiliary tissue samples? Candidate could consider the pre-dissection steps of sample preparation like inking, slicing, dissection steps and candidate's involvement like assisting or performing dissection, processing and the schedule used and why, embedding and any special instructions gastrointestinal and hepatobiliary samples might have, microtomy and any special instruction. Staining of gastrointestinal and hepatobiliary samples with various methods, possible molecular analysis and referrals of cases, QC, and block checking, digital scanning, and booking out cases to pathologists. This is very individual and depends on the training and competency of the candidate, SOPs, and methodology used. The ninth learning outcome is, discuss how cellular pathology investigations impacts the management of patients with gastrointestinal and hepatobiliary disorders. Candidate needs to know about how histology investigations impact patient management. Does the candidate know how histology investigations impact the management of patients with gastrointestinal and hepatobiliary disorders? Do they know what information can be gained from histology results that can be used for patient management? Do they know if histology investigations can affect patients' diagnosis, treatment, prognosis, or monitoring? Can they list tests that can be used in histology to guide patient management? Candidate could consider lab investigations that distinguish between benign versus malignant, in situ versus invasive, tests enabling subtyping, grading, staging, differentiation, diagnosis, prognosis, guiding therapeutic decisions, lymph node status assessment, detecting lymphovascular invasion, genomic profile monitoring, establishing predictive value, digitalization of results for sharing and MDTs. The impact of investigations like offering surgical options, therapeutic options, personalized treatment, for monitoring disease progression, monitoring treatment response, prognosis, to speed up process and improve therapeutic accuracy. Indicative content highlights background knowledge that might be assessed during the VIVA. They may or may not be demonstrated by the learning outcomes or candidate's evidence. In this submodule, candidate is expected to have the knowledge and understanding relevant to tissue processing and embedding techniques for routine histology samples, EQA schemes for tissue processing and embedding procedures, able to interpret and act upon the results. Resources section on the Brightspace contains some very useful information for this submodule. Submission of evidence section on Brightspace informs the candidate what evidence needs to be submitted for each subsection. Candidate needs to submit answers to questions that were set by the training officer. I will share some examples of possible question suggestions later on. Candidate also needs to select an additional piece of evidence relevant to this submodule. For evidence ideas, please have a look at the video for trainee. Each submodule also requires the candidate to submit their reflective statement relevant to their practice and training in each submodule. These are some example questions you could give your candidate to test their knowledge, competence, and skills about this submodule. These should be based around the learning outcomes mentioned earlier. These are some more example questions you could use for this submodule. You could ask them to complete tables you created, based on the learning outcomes. Or you could use images to test candidates' knowledge and competence. Supporting evidence should be selected by the candidate. It needs to be based around the learning outcomes and indicative content, and be relevant for each submodule. The evidence should allow the candidate to demonstrate their specialist knowledge and competence in each submodule. It should be specific and relevant to the candidate's in-house practice. If you would like to see specific ideas for supportive evidence, please have a look at the video for trainees. Each submodule also contains reflective statement, which is asking the candidate to summarize their role in the lab in the context with each submodule. How do they demonstrate that they can draw conclusion from what they have learned, reflect on their current practice and how it can change in the future due to gained knowledge? They could think about what is their lab role in context of this submodule. What impacts can their actions have on their colleagues, department as a whole and for the patients? They also need to write a personal reflection on their training in the lab, and explain why they chose their evidence. This is very personal to their own circumstance. It should demonstrate their ability to be self-aware when analyzing gaps in their knowledge. They can use it as an opportunity to reflect on aspects of their training, application of their gained knowledge and skills, and how they have achieved their goals. They should think about what their evidence demonstrates, and why they chose this specific evidence for this submodule. Also, they should write about what their training was like when it comes to this submodule and how their practice changed due to their training. Their reflective statements can also be used as a CPD evidence in case they are chosen to be audited by the HCPC. I would also like to share with you some helpful tips that can make candidates' portfolio look really good. Ask them to try and present the information in various formats such as tables, animations, pictures, posters, flowcharts, videos, photographs, PowerPoints, diagrams, graphs, infographics, charts. This nicely breaks down a lot of text that is usually present in specialist portfolios. Ask them to try and make it a little bit more interesting to the reader, which will be, and eventually the assessor. Ask them to try and put themselves in your or the assessor's shoes. How would they like to read hundreds of pages of plain text? There is a saying I really like, and it goes like this: a picture is worth 1,000 words. I will make a video where I will share with you my evidence I used for my portfolio back in the day. Hopefully that will help. Also ask them to try and use various types of evidence, not just one type, like a case study, for each submodule. They could use experiments, case studies, annotated results, troubleshooting, controls production, annotated images, risk assessments, glossary, training presentation, certificates with reflective statements, nonconformances, validations, verifications, comparisons, ECHA results, annotated audits, CAPA or DATIX, Q&A. Ask them to try and bring in their personality. Ask them to think about the ways they like to learn best. If they like experimenting, let them perform experiments. If they like troubleshooting, let them perform troubleshooting. Ask them to choose that demonstrates their specialist understanding, knowledge, and skills, and how they apply this in their practice. And one more thing, ask them to keep the learning outcomes and indicative content in mind when they are selecting their evidence. Learning outcomes that require the candidate to demonstrate something would be ideal for covering with their evidence. And this brings me to the end of today's video. Hopefully you now have a better understanding about the learning requirements for this submodule. And I hope you also have a better idea what questions you can choose to test candidates' knowledge. And my final take-home message? Keep those learning outcomes in mind when selecting questions and guiding the candidate. Bye for now.